So having Dominic come and tell us a little bit about himself is key. And then give a scientific talk about areas of interest to him. So Dominic, you have the floor.
All right, great. Can you guys hear me okay? Thanks for having me out to this wonderful winter wonderland. I'm enjoying my first Wisconsin winter. I gotta say it's pretty great so far. Okay. I've been massively increasing my stock of thermal underwear, which is a must. I noticed that did they deliberately make the hospital a little colder so that you can survive in all the garments that you have? I think seems like. So today I'm going to do a couple of things. One is I'm just going to tell you a little bit about where I come from, what my background is, so you have a better understanding of all my quirks and proclivities and behavioral mannerisms. And I don't have any pictures with any dignitaries, but I have a couple of funny pictures to show you. And then I'm going to go into the problem of improving outcomes in critical brain injury. And I think that there are some interesting preclinical and clinical science that I want to share with you, but there's also just some very basic, massive problems in critical brain injury or severe brain injury that we just need to work towards shedding more light on that I want to share with you. So I was born into a family of, this isn't working. Okay. Oh, do you need to plug this in? Here we go. I was the second youngest of 6. That's me on top of the head, and that's my dad was a remodel contractor. So I spent my childhood digging under houses, laying down vapor barrier, and generally crawling in places that you shouldn't go. I was still of the age where you were just turned outside after school, and then you didn't come back until the sun set, and generally was just unsupervised my entire childhood, for better or worse. When I got into middle and high school, I fell in with the wrong crowd. I became a total band nerd, and music became my passion, and academics was certainly not. I think I graduated high school with a 1.9 or 2.0 GPA. And I'd say if a few different things happened in my life, I probably wouldn't have gone to college. And the biggest factor was I was in a good school and everybody was going to college. So I figured I better go do the same thing. So I ended up in California State University in Long Beach, majoring in music. And I always tell people if they had had a marching band at that university, I would be living a very different life now. What I found out there was that I didn't like practicing at all. And I was not doing well in university. And I was actually spending more and more time working at my retail job, which was at a camera store selling cameras and doing 1-hour photo. And the reason I share this with you is because I think that my experience working in retail was probably one of the most valuable experiences of my life and gave me many of the tools that I rely on to this day on interfacing with patients and their families. And there's a few important things that I learned. I think every angry customer can be transformed into a loyal customer if you use the right approach and you make sure that they feel like they're heard and that you are on their side. And this rule applies to patients and their families as well. I also know that you can convince anyone to buy anything if you give them the right pitch. And I think what this speaks to is that our words in talking to our patients have a massive effect on their decision-making when it comes to whether or not they want to do a surgery, whether or not they want to continue with full care later on. And they rely heavily on the advice that we give them. And then the customer is always right unless they're misinformed. And what that really means is that you quickly learn that disagreeing with somebody in a conversation about something is not a productive way of changing their mind. And what you really have to do is help families and their patients come to the right conclusions by making sure they have all the information. You can't tell a patient they're wrong, but you can always give them additional info. I think these are really important. During this time, I was avoiding school, working at my job, and decided that I didn't want to do music anymore. And I had a good friend who convinced me that I should focus on biology and challenge myself to get the grades for medicine. And so I turned things around and ended up being able to successfully apply to an MSTP program, because part of getting into medical school is doing research. So I just joined the first lab I found, didn't even know what they were doing, but quickly fell in love with the scientific method and realized that I wanted to do both research and medicine for the rest of my life. During med school, I met my beautiful wife, Janelle, and we've been together now, oh God, I think it's almost 20 years, and married for 13 of those. And she's, of course, been the rock of my life, and making sure that everything else gets done as I let it fall apart around me, especially during residency, as I'm sure you guys understand. Right before I joined neurosurgery residency, I had my first child, my daughter Esme. She's 10 now. It was certainly a challenge to raise kids through residency, but with the help of a good spouse, it is totally doable, as some of you are experiencing now. And then soon after, I got my little boy, Bastion. He's a bit of a train wreck, but he's cute as can be and is doing great. And they were both wonderful additions to the family. We spent a year apart after residency at OHSU. And during that time, I did my neurocritical care fellowship. And I learned a lot about not only outcomes in critical brain injury, but also that there are many opportunities for growth in the field of neurosurgery that come from different specialties who are making amazing advances in critical illness that haven't caught up with neurosurgery yet. So, to get right into it, first I want to tell you about some of my mentors. Nabil Al-Tayed was my PhD mentor. I was with him throughout grad school, and I still work with him today. He has been incredibly important in my life, and has taught me everything that I know about research and writing, and we still talk on a regular basis. And then another important mentor for me was Dr. Justin Cetus. He was just out of training when I first started in the lab, and it was his preliminary work in subarachnoid hemorrhage, which inspired some of the work that I'm going to show you today. And I worked very closely up with him all the way up until he left OHSU to chair University of Arizona. And of course, he unfortunately passed away there. Otherwise, I might be dealing with the heat instead of the cold. He served as a huge inspiration because he's one of those people who always had an optimistic outlook for his patients, regardless of what neuroexam that they presented with, and was always fighting for them to pursue extended care to allow time for the brain to heal, which we know takes a long time. Some of his inspiration actually transformed into a conference that we created there, something that I'm hoping to start here, that was supposed to be the antidote to mortality and morbidity conference called Vibrancy and Vitality Conference. We talk about the very difficult patients who pull through and recover in the long term to help us understand, the pathway for brain recovery. That conference actually won an ACGME National Award for physician wellness. So more on that later. So how do we improve the outcome of our patients with critical brain injury? I'm talking about severe TBI. I'm talking about high-grade subarachs. I'm talking about intraparenchymal hemorrhage. I'm talking about large MCA infarcts. This data is from TBI, which I think is the one that's most talked about lately, but these statistics apply largely to anyone with a severe brain injury. And that is that the vast majority of deaths that occur in patients with severe brain injury are due to withdrawal of life support. And when you look at the percentage of those decisions that are made, that they're usually made within the first 72 hours. This is a study of 6 Canadian level 1 trauma centers. And what it's showing you in the left figure is the odds ratio for mortality and the variability between those centers. And I promise you that that's not a variability in the skill of the neurosurgeons or the physicians that are taking care of the patients, but it's a variability in the philosophical approach to severe brain injury and neuroprognostication and the counseling that we give to the patients. There are some places where 92% of the patients that die from withdrawal life support happen within the first 72 hours, and other places where 50% occur, large variations. Overall, though, I think it's been well understood now that neuroprognostication within the first 72 hours is risky business, because it's very difficult to tell what the trajectory of the patient is going to be during that time. To even drive it home even more, this is a great use of the track TBI data. What they did in this study was they took the patients from track TBI who had withdrawal support and those that did not have withdrawal support, and they propensity matched them. So they said, these patients met the criteria for withdrawal of life support, and compared them to the ones that did or did not undergo withdrawal of life support. In other words, what would have happened if they had not withdrawn care? And what they found was that care was withdrawn on 30% of patients that had a reasonable chance for a good outcome. Mortality is still very high. I would say that this doesn't mean that they're absolutely going to have a good outcome, but it means that we're leaving good outcomes on the table when we're neuroprognosticating and counseling our families and patients on next steps. This is a great little study looking at the ability of a neurosurgeon and a neuroradiologist to neuroprognosticate within the first 24 hours of admission of the patient. And this is frankly what we do all the time. I'm doing a mini prognostication when you guys call me and tell me the exam, and I look at the imaging. And that's the information that this neurosurgeon had for this study. What they looked at were 3 groups. Group 1 was dead or in a vegetative state. Group 2 was severely disabled, and Group 3 was independent. And what they found was that the neurosurgeon only correctly identified the outcome of the patient 35% of the time in the independent recovery group, 3% of the time in the severely disabled group, and 18% of the time in the dead or vegetative state. The radiologist was much more optimistic and correctly identified those who had good outcomes, but did not do a great job with those who had poor outcomes. When you break this down, what you see is that essentially prognosticating in the first 24 hours based on the clinical exam and the radiological imaging is essentially just a little better than a coin flip as far as their outcome. And that in general, neurosurgeons tend to overly negatively bias their prognostication. In this study, 14% of the patients who had a good outcome were predicted to be dead or in a vegetative state. 19 of the patients who had severe disability were predicted to be dead or in a vegetative state. So what is important for this study is an acknowledgement that we really don't know how the patient is going to do. I think focusing down on some of the more common reasons that we don't take someone to surgery when they show up with a no exam and bilaterally blown pupils. Oftentimes people say this is futile, you can't take them, that their outcome is going to be universally poor. And this study in 2023 looked at 43 patients with blown pupils and herniation syndrome who did get surgery, and found that at 3 months, 30% of them had a favorable outcome, were independent, and had moderate disability. 40% died and 30% unfavorable outcome. To me, this doesn't mean that they're going to get better. This isn't what I'm trying to tell you. What I'm trying to tell you is that these percentages and these odds are actionable and not futile. Interestingly, from this study, and I think this is something that I'm going to incorporate more in my practice, which is when they looked at those patients that ended up with a good outcome, they found that having a pupillary response either to osmotherapy or to the decompressive surgery was the category that all of the patients who had good outcomes fit into. So assessing how the patient responds to your initial interventions can be informative as far as whether or not the patient is going to do well. Another thing that's really important is we're not good at making sure we give them enough time for the 72 hours, the minimum 72 hours for neuroprognostication. We're not good at making sure that we take every patient who has a chance for a good recovery to surgery. But also recovery of basic command following takes a lot longer than you would think. And so what this study was looking at was patients who were admitted to rehab therapy with persistent disorders of consciousness, on average 47 days after injury, and observed for 6 weeks. And in the blue, this is the percentage of the subjects that were successfully performing these tasks: command following, object recognition, object use, intelligible speech, reliable yes or no communication, sustained attention. And after the 6 weeks, this is the percentage of the patients that were doing these targeted behaviors. I think what's really important is this number down here, which is if you look at patients who had 0 of these functions at the beginning of this study, 47 days after the injury, 47 days, it was 90% of the patients had no command following or other functional outcome. By the end of the 6 weeks, 60% of the patients were following commands and had some domain recovery. If you look at patients who leave the hospital in a minimally conscious state versus a vegetative state, so a minimally conscious state, we're talking about perhaps some limited command following or at least signs of consciousness, eye opening, and sleep cycles, versus those that have no features of wakeful state or communication. Clearly, those that were in a minimally conscious state did better than those that were not with regards to recovery of targeted behaviors at the end of the 6-week period. So 47 days, that's over a month, and another 6 weeks on top of that. We're talking 3 months. We're seeing a large percentage of patients who are continuing to improve their neurological exam, who are otherwise unresponsive when they discharge from the hospital. This is a study looking out even further, 5 years. We often talk about how kind of recovery peaks at 6 months, 1 year, something along those lines. These are the percentage of patients who, on enrollment in the study, were performing these functional activities: grooming, bathing, dressing, these kinds of things. It was 8 to 20%. And then after, at 5 years, that number was up to 60 to 80% of those people are independently functioning at those levels. Then they looked out 10 years. And what they find is that the patients divide into different groups. Some patients don't get better at all. They don't change, they don't improve, they don't regain any functional independent status. But there are groups of patients who, over the course of 10 years, continue to improve dramatically in their ability to be functionally independent. So it doesn't happen in the first year, it doesn't happen in the second year, it happens continuously over the course of a decade. So some of the things that we can do right off the bat, I think, to improve our outcomes here at the university is making sure that we're all acknowledging that there's uncertainty and that there's bias in our first pass surgical decision making that happens on the ground floor when the patient hits the ED. We can also resist the urge to neuroprognosticate for the families, even though they're asking for more and more information, to help them understand that we need information to see what they're doing, and they need time before we can make an assessment of their potential for recovery. And then we need to extensively counsel the families on the amount of time that recovery is going to take and what that's going to look like for them in the future. Some system improvement things that I think can help with these issues is building infrastructure to buy more time. And one of the things that I'm working on implementing here is a program for limited time trials for brain injury patients. And what that means is when a patient's family makes a decision about a feeding tube and a tracheotomy, they're often feeling like they're making that decision forever. And that doesn't need to be the case. What we can do is establish fixed time points by which we can assess the progress of the patient and determine whether or not they're meeting goals for recovery from brain injury. And at those periods, working with palliative care, we can develop a program where if they're not meeting the goals for neurorecovery and they've had sufficient amount of time, at that point, they can transition, that they don't have to do it right in the hospital right away, and the patient can be given a chance for recovery. Dr. Belton is already doing some awesome work establishing a long-term multidisciplinary clinical care track for brain injured patients. That's going to continue to grow. I know that the rehab department is recruiting more individuals for brain injury. Our access to inpatient rehab from this institution is extremely limited. Even as so far as something as simple as taking patients who require a ventilator, either at night or all the time. Those patients have a lot of recovery potential, and they're often missing out on their opportunity for rehab because we don't have any respiratory support for brain injured patients. So those are some of the simple programmatic and kind of surgeon-specific things that we can change without any advanced science on improving outcomes for our patients here in the hospital. Just giving them more time so that patients have an opportunity for recovery. What about more specific things, looking at preclinical science and early clinical trials? And so what I want to share with you is one particular aspect of secondary brain injury that occurs in subarachnoid hemorrhage patients. We're talking about delayed vasospasm, or the more specific term is delayed cerebral ischemia. I want to tell you about a pathway for research that we're pursuing that will culminate here in an investigator-initiated clinical trial. So we all know about subarachnoid hemorrhage and the rupture of an aneurysm. I don't have to go into detail about that. We know that there are many secondary injuries that occur after the initial hemorrhage, including acute hydrocephalus, rebleeding, cerebral edema, and the big one that we talk about all the time is delayed cerebral ischemia secondary to vasospasm or alongside vasospasm, and that this has a substantial impact on the overall mortality and morbidity of this disease. When you think about delayed cerebral ischemia, I want to separate it from vasospasm because there's actually been some fantastic clinical trials that do a really good job of ameliorating vasospasm, but have very little effect on the development of strokes and delayed cerebral ischemia on patients. But when we talk about delayed cerebral ischemia, we're talking about impaired cerebral blood flow at the level of the parenchyma and the microvasculature. And a new onset neurological deficit or infarct presents 5 to 14 days after subarachnoid hemorrhage and affects 30% of survivors. We have things like TCDs and EEG to help us identify patients who are suffering that, but those are not perfect. And so the who's going to get vasospasm still remains difficult to predict. And we don't have any new therapies since the creation of nimodipine, probably getting on 40 years now, that are FDA approved for treatment to prevent this complication. When we think of delayed cerebral ischemia, we think of delayed vasospasm. The problem with that is there were some fantastic trials in the early 2000s looking at clazosentan, an endothelium receptor antagonist for reversing vasospasm. It did a phenomenal job, and large vessel vasospasm was thought to be on the verge of being completely reversed in these patient populations. However, when they did the phase 2 and phase 3 clinical trials, they found that there was really no impact on the actual ischemic events that these patients were experiencing, which makes us think, well, maybe the problem isn't actually with the large vessels. Maybe the problem is actually at the level of the parenchyma and the microvasculature. And that's where my work in my graduate studies comes into play. I focus specifically on a derivative of arachidonic acid known as P450 icosanoids. 20-HEAT is a potent vasoconstrictor of cerebral microvasculature, and then EATs, or epoxy icosanoids, are potent vasodilators. Importantly, EATs is regulated by the enzyme soluble epoxide hydrolase, which converts it into a inactive metabolite. So we looked at whether or not mice with knockout of this enzyme, soluble epoxide hydrolase, and theoretically more EATs in their body would be protected from delayed cerebral ischemia. These are just some Western blots showing that we were able to knock it down in this animal. So we did the endovascular puncture model of subarachnoid hemorrhage, and this is just an example of the model. You can see the blood tracking nicely along what we know now is the lymphatic space. And then, of course, the effect on cerebral blood flow after the hemorrhage. We use a technique called optical microangiography, which allowed us to visualize the vasculature within the skull repeatedly without actually opening the skull. So we could image the animals over time and look at the changes in their microvasculature. So we did find a model of a delayed decrease in microvascular perfusion in these animals, and the ACH knockout mice were protected. So this is our first evidence that maybe this enzyme might be useful as a therapeutic agent. We also found that these EATs play a role in suppressing neuroinflammation. So EATs act on NF-kappa B and suppress the activation of pro-inflammatory markers such as BCAM1, and this reduces adhesion of the white blood cells to the endothelial cell wall and disruption of the blood-brain barrier related to that. We use a technique using a 12 Tesla MRI with VCAM labeled iron oxide particles, and found that subarachnoid hemorrhage 24 hours after, of course, very large increase in VCAM expression in these animals, and that soluble epoxide hydrolase knockout mice did not have this same increase in their neuroinflammatory cascade. We looked at EATs and HEATs in humans and found that they had high levels of both, and that these molecules are associated with delayed cerebral ischemia. In fact, this CSF EATs levels is a stronger predictor of delayed cerebral ischemia than something like Lindegard ratios on TCD. So very closely associated with delayed cerebral ischemia. The thought is that the balance between this vasoconstrictor and vasodilator molecules is disrupted, and our next step was to identify a method by which we could change that balance. One other thing we did in patients was look at mutations in soluble epoxide hydrolase. There are two known polymorphisms, one of which increases SEH activity and decreases EATs, and the other one decreases SEH activity and increases EATs. We found that patients who had increased SEH activity had more strokes and a higher mortality after subarachnoid hemorrhage than patients who were wild type or had the protected mutation. This all led to a small clinical trial of an enzyme inhibitor of soluble epoxide hydrolase in patients with subarachnoid hemorrhage. This was focused mostly on safety, which we demonstrated. There were no increase in adverse events. But we did collect some data on the biological efficacy of the drug and found that we were able to increase plasma EATs substantially. We did not have an impact on CSF icosanoids, though, suggesting that the drug was not crossing the blood-brain barrier. We did have an impact on CNS inflammation, and we were able to reduce those biomarkers, many of which were not statistically significant because it was not powered for this. It was a small safety trial. And then also we found that patients who had the inhibitor had a decreased ICU length of stay, and they were more likely to go home than those that were receiving the placebo. So all very promising for a very early safety trial, suggesting that we should continue to the next steps. Of course, GSK was not interested in using this drug for subarachnoid hemorrhage. They had developed it for lung disease, and that was not panning out. So they stopped producing that drug. But we did connect with a company, Icosis, which is producing EC5026, a very similar molecule that has the same enzymatic property and actually crosses the blood-brain barrier much better than the GSK drug. And now we're working with them to develop a phase 1, phase 2 clinical trial here at UW. We're going to use a novel PET radiotracer called 18F-FNBP, which crosses the blood-brain barrier and binds to the SEH enzyme, give you a measurement of SEH activity. So this is measurement in patients, in healthy patients, and this is a map of non-human primates that received an inhibitor, and the dose response of the PET radiotracer when receiving the inhibitor. So what we'll do is we'll use this to verify the target engagement of our new molecule in the CNS, which is a very important step in moving a drug through to translation into patients. This will look like a modified phase 1/2 study where we'll have a low dose and a high dose. We'll use primary outcomes for safety and then develop surrogate biomarkers to verify that the drug is doing what we say it's going to do, affecting neuroinflammation, increasing eicosanoids, and then, of course, as tertiary endpoints, we'll look at the disposition of the patients, hoping to get that up and running sometime next year. So that is when you think about translational medicine, you think about bench to bedside. And what it really means, for me anyway, translational medicine means I'm operating at the border between clinical and preclinical studies. So that is a very early phase clinical study. The next step is for me to demonstrate some early biological efficacy in that, and then move to pass that on to one of the larger stroke net groups who's going to administer it in a very large multi-center clinical trial. And in the meantime, I'll be working in the late stage preclinical testing to develop the next therapy that will then move into early clinical trials. So what I'm trying to do now is establish what the next step is going to be. And that is looking at the role of small molecules in secondary brain injury. So secondary brain injury is a broad category. It's a number of different things, and it's probably the most important thing affecting the outcome of your patients after they get to the hospital. And it's probably happening right now under your nose without any kind of measurement or understanding of what's going on. Essentially, at the moment of reperfusion, either from your decompression or from removing the clot from a stroke, or restarting someone's heart after cardiac arrest, additional injuries occur to the brain due to reperfusion injury. And then there is a plethora of different things that happen over the course of hours and days and weeks that contribute to increased injury. One of the ones that we think about the most is intracranial pressure due to cerebral edema, which occurs, can peak 24 to 72 hours after the initial injury. But we have excessive glutamate release leading to phenomena such as neuronal excitotoxicity and cortical spreading depolarization. And then we have blood-brain barrier compromise and neuroinflammatory cascades that lead to worsening outcomes due to overzealous inflammatory response. So what we're looking at is how those mechanisms of glutamate release, blood-brain barrier compromise, increased ICP, cerebral edema contribute to the inability of the body to deliver oxygen to neurons. And that can occur in two different ways. One is by impairment of convective oxygen delivery. And that is, what I mean by that is the train by which red blood cells are delivered to the vessels of the brain. We know that intracranial pressure affects cerebral perfusion pressure, and that is exacerbated by cerebral edema, which impairs the balance between ICP and mean arterial pressure. We also have contributions of hypoxia and anemia as individual contributors to the impaired delivery of oxygen to the site of diffusion. But there's another mechanism here that is becoming more apparent now with increased use of brain tissue oxygenation monitoring. And that is, you guys don't have a lot of experience with brain tissue oxygen monitoring, but there's a subcategory of patients where they have normal ICPs, but they have impaired brain tissue oxygenation levels. These are a big mystery to people. We talk about treating them with transfusions, optimizing their ventilator status. But what they're finding more and more is that there's actually an impairment at the neurovascular unit that is preventing the oxygen from moving out of the vasculature into the brain parenchyma. Thought to, at least in part, be the mechanism underlying that being the cerebral edema. So just to briefly talk about excitotoxicity, when you have normal synaptic transmission, glutamate is released from the postsynaptic gluton and acts on the NMDA and AMPA receptors here. And then that excess glutamate is taken up by astrocytes and recycled back into the signal cascade. When you have excitotoxic synaptic transmission, this release of glutamate overwhelms this system, and the glutamate levels build up inside the extracellular space where glutamate is normally in very low concentrations. And that leads to abnormal signaling and cell death. When we think about cerebral edema, there's several different mechanisms. When you think of cytotoxic edema, what you really are having is uncontrolled depolarization and loss of membrane integrity that allows ions to flux into the cell. Once ions flux into the cell, water quickly follows. And while water follows whatever osmotic gradient is present. And once water leaves the extracellular space, you now have a hyperosmotic extracellular space, which then brings water in from the vasculature. Not only that, but I think it's important to recognize here that blood-brain barrier compromise, even though it's described here as a single hump, is transient and biphasic. So you have an early opening of the blood-brain barrier, and then it recloses, and later on down the line, hours and days later, you have a reopening of the blood-brain barrier, thought to be secondary to neuroinflammatory cascades. So we know how cerebral edema contributes to elevated intracranial pressure and how intracranial pressure leads to decreased cerebral perfusion pressure and decreased cerebral blood flow. I think what's important to realize that for every 1% increase in brain water content as a 5% increase in cerebral edema. So 1%, we're talking, we look at brain water content, something jumping from 77 to 80, and these lead to substantial increases in intracranial pressure. So it doesn't take much to overwhelm the brain and lead to impaired compliance and elevated intracranial pressure. When they look at patients with traumatic brain injury and they do EM studies of the neurovascular unit and the parenchymal microvasculature, what they find is that the neurovascular unit is distorted by this edema. And now you have a path by which oxygen must diffuse from the endothelial cell across this chasm of edema to get to the neuropil. And that barrier represents a diffusion barrier. What they find when they measure jugular venous bulb oxygenation is that in patients who have this deficit, they have very little change in their CMRO2, their metabolic uses of oxygen, even though their brain tissue oxygenation remains very low. So they're not pulling oxygen out of it doesn't matter how good you get the cerebral blood flow, they're not pulling the oxygen out of the vasculature and into the parenchyma. So what is a way that we can tackle this? One way is looking at the blood-brain barrier as this transient opening and closing. Once it's opened and then closed again, you now have two compartments that are separated by a membrane, aka a place for osmotic pressure to develop. And the blood-brain barrier is made up of many tight junctional proteins. One of the most abundant is Claudin-5 here. This is the membrane that plays as the main key factor in developing cerebral edema, because if the blood-brain barrier was open, you'd be unable to develop a gradient that would then generate the osmotic pressure to drive cerebral edema. So this is the slide looking at the transient opening of the blood-brain barrier. So I'm working with a colleague, Matt Campbell, who has shown now that siRNA directed at Claudin-5 can selectively open the blood-brain barrier to only small molecules, molecules that are less than 800 Daltons, which the molecules that fit into that are important for osmotic gradients are glutamate and several of the important ions for maintaining cell gradients. Interestingly, when they deliver siRNA, they can open the. There's actually two molecules injected, one large molecule and one small, and you can't see any of the red from the large molecule in the Claudin-5 injections. And this is a transient modulation. It lasts about 72 hours, and then the blood-brain barrier closes again to small molecules. So with Claudin-5 siRNA, we can selectively modulate the blood-brain barrier to open the barrier to any small molecule buildup that's in the parenchyma and allow that to transition down its concentration gradient back into the vasculature. Dr. Campbell has done work in mice with brain injury and found that using Claudin-5 siRNA actually reduces the amount of large molecule blood-brain barrier disruption and decreases the brain water content in these animal models. Additionally, modulating the blood-brain barrier with Claudin-5 decreases the expansion of the lesion size at 72 hours. It increases cerebral blood volume, and you can give it here in the red and the black bar. This is at 6 hours after and 24 hours after. So this is theoretically acting on that hours to days cascade that's occurring after the initial injury. When he looked at neurological function, we found that he can improve the neural score of the mice receiving the siRNA and reduce the amount of neurons that are dead on histology. So the goal here is to develop a large animal model for modeling brain injury closer to human physiology. Gyroencephalic non-ruminant animals like swine are the best model for this. And then bring in all of the cerebral physiology equipment that we use in humans and model those in the animal and study this particular pathway and the role of these small molecules in the development of the secondary brain injury. I don't have any preliminary data for you guys yet because we're still getting the lab set up. And so that's just a little taste of what we're working on next. And that's where I'll stop. Thanks.
Dominic, this is a great description of a long-standing problem where you're finding the tools are catching up with the question and beginning to come to an understanding of this idea of small vessel spasm has always been there, difficult to prove. But if you look at the patient course of the people that improve, it's screaming that something's happening at the end of the third week. Have you seen a change in the levels of those proteins you've been studying over time? Like you have people that have high and have low, and these do better and these do worse, but do they change over time? Does that happen at the end of the third week?
So the pro-vasodilatory and the pro-inflammatory markers have opposite time courses. The 20 heat molecule, which is pro-vasoconstriction, peaks high and then decreases over time. And then the pro-vasodilatory lipid, the 14-15 EATs, actually slowly ramps up over time.
When did they cross?
When is it? What?
Yeah, when did they cross? When,
Because actually have that data right here. So we can look at the time course here from this study. The levels are not comparable, but you can see around the 7 to 10 time point is when we start to see a ramp up of the what we think is a response to ischemia that's occurring in those time points. And this one is declining.
Great.
Thank you.
This is the sort of idea that you begin to use the science of the time to look at this. Patients have been telling this, the survivors have been telling us this for decades. And, why did they suddenly become more conscious, the ones that survived, and when did it happen so stereotypically? And what he's trying to do is tell us how. And more tools, we'll find more proteins, and we can change them. And he's also showing there's two ways to do it. One is protein markers, one is genetic markers, especially as being to look at RNAs. That's Dr. Ben Liganti's lab. These are all the people we have here to help us get to the bottom of this.
I think what's really important is the recognition that right now, what we're doing for our patients is largely supportive, and that there is ongoing injury and things that are negatively impacting ultimate neural outcomes for our patients that we can actually act on if we can identify them and intervene, even at the point of prior to surgery or at the time of surgery. There are ways to make our surgeries more effective as well using these approaches.
I want to emphasize the point that you made about the retail interaction, and in approaching these brain injured patients, the way that you frame the decisions can really ultimately guide the patient's families ways that are surprisingly direct. If you come to a brain injured patient's family and ask them, do they want a tracheostomy type 2? Nobody has that as a life goal. When I reach 60, I would like to have a tracheostomy. But if you frame it in terms of, are they up for a recovery? Would they be up for the challenge of through an illness and potentially recovering from it? Oftentimes they're up for that change. So thinking about the language that used to approach these patients, what and their families, and what's successful, and getting them over that hump will often determine whether or not they're being successful in the condition.
And I find it's a really common misconception among families that once these tools go in, that they can't come out. So I find myself constantly having to update their information about how we use those tools to support recovery. Thank you.